Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Welcome back to the deep dive. Today we're focusing on something really central to modern hernia surgery. It's less a single structure maybe and more a whole surgical concept.
The Myopectineal Orifice, the MPO.
Exactly. Described way back in 1956 by Henri Frouchot. And it wasn't just naming a spot, it really felt like it gave surgeons a totally new map, a unified way to approach groin hernia repair.
Oh, absolutely. It truly redefined the whole pathology.
Yeah.
Before Frouchot, surgeons often treated inguinal and femoral hernias as, well, completely separate things.
Right, like different diseases almost.
The MPO concept just cut through that. It revealed the underlying truth, the key, really, that unlocks how we do comprehensive repair today, especially laparoscopically.
So our mission today, for you, the surgeons and practitioners listening in, is to really distill the core anatomical facts, the surgical relevance, and importantly, the technical precision you need to master the MPO.
Particularly for lap repair, yeah.
Yeah, specifically for laparoscopic hernia repair, we want to give you that blueprint for competency.
Okay, but before we really dive into the sources and the details, we absolutely have to cover some essential context.
Yes, the necessary disclaimer.
It's crucial here. Given how specific and technical this is, and that it's really for educational reference for medical professionals, we have to stress this. The information today is purely for reference.
Right.
In your actual clinical practice, making decisions for patients, you must always follow your local institutional guidelines, your established protocols, and, current best practices. That's non-negotiable.
Understood. That's the foundation for everything we discuss. Okay, so with that covered, let's zoom in on Frouchot's, really disruptive idea back then.
It really was.
He proposed that the MPO is a genetically determined weak area, which led to that pretty famous and slightly unsettling quote.
A healthy man is, unknown to himself, a hernia bearer.
Yeah.
Chilling, but it captures the essence.
It really does. What did he mean by that, essentially?
Well, that statement just encapsulates the whole paradigm shift. It implies we're all kind of walking around with this potential defect, an inherent structural flaw, almost, just waiting for the right conditions, the right pressure to fail.
So the MPO isn't the hernia itself, but the potential space.
Exactly. It's this single funnel-like potential space deep in the lower anterior abdominal wall. And through this space, all groin hernias, inguinal, femoral, eventually emerge if that underlying fascia gives way. It provided the unified field theory, if you like, for groin hernias.
Okay, let's unpack the anatomy then. If the MPO is this single region, we need to know its borders instinctively, like muscle memory for surgeons. So starting at the top, what's the superior boundary? What holds things up?
Okay, superiorly, you've got the arching fibers of the transversus abdominis muscle and the internal oblique. These come together, forming the conjoined tendon in many cases. That's essentially the roof of your operative field.
And moving medially.
Medially, the boundary is the lateral edge of the rectus sheath and, of course, the rectus abdominis muscle itself. Pretty straightforward there.
Okay. And then going down, the inferior margin. This seems absolutely critical, right? Especially for mesh placement and fixation.
It is. Hugely critical. Inferiorly, you're dealing with strong, quite rigid structures. You've got the iliopectineal line, the pecten pubis, and crucially, Cooper's ligament.
Cooper's ligament, always a key landmark.
Always. It's that tough, white, fibrous band, very reliable fixation point, as you know. Yeah. And then laterally, the boundary is formed by the iliopsoas muscle complex and those arching fibers that come off the inguinal ligament.
So we have this space enclosed by muscles and ligaments, but which specific layer inside that space is the one that actually fails? Where's the breakdown that leads to the hernia?
The critical layer, the one that matters most functionally, is the transversalis fascia. Think of it as the deep layer that's meant to keep the MPO closed off.
The barrier itself.
Precisely. The whole concept of hernia formation hinges on defects or weakness in that specific fascia. If the transversalis fascia fails, the barrier fails, and abdominal contents can start to protrude.
Now, to really appreciate the surgical task, we need a sense of scale. We're not just patching a tiny hole, are we? I know the sources mention specific measurements from cadaver studies about the MPO's size.
They do, and it's important context. These measurements really highlight the geometric challenge. The average MPO has a mean width of about 7.1 centimeters.
Okay.
And a height of roughly 6.7 centimeters. So if you calculate that out, it gives you a mean surface area of around 37, maybe 37 and a quarter square centimeters.
37 square centimeters. Wow.
Yeah. So like you said, you're definitely not repairing a pinhole defect. You're reinforcing an area roughly the size of maybe a small credit card, maybe a bit bigger. And that reinforcement, that mesh coverage, needs to be robust enough to last.
That really does put the need for complete coverage into perspective. Okay, so we have the outer borders. Now, how do we use landmarks inside the MPO to subdivide it and map out where the different hernia types actually occur? What's the main dividing line?
The primary dividing line, especially from the laparoscopic view, is the inguinal ligament, or perhaps more accurately termed, the iliopubic tract when you see it from behind.
Right, the internal view.
Exactly. That tract divides the MPO into the superinguinal region above it and the subinguinal region below it.
And the superinguinal region is where we find most common hernias.
That's right. It encompasses the vast majority of both direct and indirect inguinal hernias. The subinguinal region below the tracts is primarily the domain of the femoral canal, and therefore femoral hernias.
Okay, so within that upper superinguinal space, there's another key landmark for pinpointing the type of inguinal hernia.
Yes, absolutely. The inferior epigastric artery and veins. These vessels become your crucial landmark, your anatomical compass within that superinguinal zone. They create the framework that defines a direct versus an indirect defect.
So how does that work, medial versus lateral?
Exactly. When you visualize this laparoscopically, anything medial to those inferior epigastric vessels in that suprarmedial compartment is a direct inguinal hernia. This corresponds perfectly to the classic Hesselbach's triangle.
Got it. And therefore, an indirect inguinal hernia
Is lateral to the inferior epigastric vessels. It's exiting through the internal inguinal ring, following the path of the spermatic cord or round ligament.
Okay, direct is medial, indirect is lateral, and the third type, the femoral hernia.
That one's in the lower compartment. It resides below the inguinal ligament or iliopubic tract in that subinguinal space. It travels down through the relatively narrow femoral canal, medial to the femoral vein.
So this mapping really reinforces Frouchot's point, doesn't it? Direct, indirect, femoral, they might look different, but they're all just variations on failure within that single underlying weak zone, the MPO.
Precisely. Geometric manifestations of that one fundamental weakness.
And this is where the MPO concept really flexes its surgical muscle, so to speak. This unified understanding completely changed the game, didn't it? It really drove the adoption of laparoscopic techniques like TKP and TEP. Why is the MPO idea so fundamental to lap repair?
Because it gave us the rationale, the blueprint, for the unified mesh principle. In traditional open surgery, often the goal was just to find and close one specific hole, the direct defect, or the indirect sac.
Right. Target the obvious problem.
Yeah. But laparoscopically, we generally stop chasing the individual hole. Instead, we reinforce the entire region. The whole approach is built around placing a large piece of mesh, a prosthetic, designed to cover the entire MPO, all 37-odd square centimeters of it.
So it's like preventative maintenance for the whole area, not just fixing the current flat tire. You're essentially treating potential weaknesses at the same time.
You've got it. And a huge advantage driving this is the superior visualization you get with the laparoscope.
You can see everything much better.
Much better. You get this high-definition magnified view of the entire MPO. This lets surgeons identify occult hernia's small, maybe subclinical defects. Could be a small direct bulge, an unnoticed indirect sac, a hidden femoral hernia, even something in the obturator space occasionally.
Things you'd likely miss in an open repair focused just on the main bulge.
Almost certainly would miss them in many open approaches. And missing, say, an occult femoral hernia during an inguinal repair is basically a guarantee of future recurrence or problems down the line. Laparoscopy lets you see and address everything at once.
This focus on comprehensive visualization logically leads to a key standard that's emerged, the critical view of the myopectineal orifice. I know this is modeled on the critical view of safety concept from gallbladder surgery.
It is, and it's incredibly important. It represents that evolution towards maximizing safety and ensuring consistency in hernia repair, just like we saw with LapCol.
So what does achieving that critical view actually entail?
It means committing to a really standardized, stepwise dissection. You don't place the mesh until all the key anatomical landmarks that define the MPO are clearly, unequivocally isolated and seen. We're talking Cooper's ligament, the inferior epigastric vessels, the iliopubic tract, the cord structures or round ligament, the gonadal vessels. Everything needs to be visible.
And I understand there are even scoring systems being developed now.
Yes, often tied to video review. These systems aim to objectively evaluate how well a surgeon achieves this critical view. It's vital for teaching, for quality assurance, for making sure the procedure is done safely and effectively every single time. Reproducibility is key.
Okay, so achieving that critical view sets the stage for the mesh, and we know mesh coverage is paramount. The sources consistently say the mesh needs to extend 3 to 5 centimeters beyond the anatomical boundaries of the MPO. Why that much overlap? Why not just size it precisely to that 37-centimeter area we talked about?
That overlap, that 3 to 5 centimeter margin, is the essential buffer zone. And failing to provide it is, frankly, one of the primary reasons for hernia recurrence after lap repair.
Why is it so critical? What happens without it?
Well, tissue isn't static, right? Post-operatively, you get tissue shrinkage. The mesh itself can contract slightly over time, and there's always potential for movement or displacement due to intra-abdominal pressure changes, coughing, straining, etc.
I see.
That generous overlap compensates for all that biomechanical dynamism. It ensures the mesh stays securely anchored well beyond the edges of the weak zone, preventing it from shifting and exposing a corner of the MPO down the road.
And the statistics on recurrence when the mesh is too small are quite striking, aren't they?
They're damning, really, for poor technique. Our sources hammer this point home. Insufficient mesh size and inadequate overlap are major drivers of recurrence. Some studies report that a staggering 0% of technical recurrences were linked directly to meshes that were simply too small or positioned badly without enough overlap.
60% just from mesh size or placement? That's incredible.
It really underscores why this isn't a minor detail. It justifies the whole push towards using appropriately large meshes and meticulous placement.
So practically speaking, what size meshes should surgeons be aiming for?
Well, the common workhorse is often a 15 by 10 centimeter mesh, and that works well in many cases. But the data suggests tailoring it a bit. For smaller defects, maybe a 13.2 by 10.4 centimeter mesh could be adequate. For larger defects, or especially in recurrent hernias, stepping up to a 15.6 by 13.0 centimeter size is probably wise.
But the principle remains the same.
Absolutely. Cover the entire MPO with generous 3 to 5 centimeter overlap on all sides. That's the goal.
Now, related to mesh, there's been a clear trend away from cutting slits in the mesh to accommodate the spermatic cord. What was the thinking behind getting rid of those slits?
That was another really crucial realization in optimizing the technique. Those slits, while they seemed practical for fitting the mesh around the cord, essentially created weak points, little keyhole defects.
Engineered weak spots.
Exactly. They became points of high stress concentration, prone to tearing or allowing recurrence through the keyhole itself. One very influential study showed a dramatic drop in recurrence from 2.8% down to just 0.36% simply by using larger meshes and eliminating those slits. It ensures complete, uninterrupted reinforcement of the entire MPO floor.
Makes perfect sense. Okay, let's shift gears slightly to advanced technique, particularly for surgeons using the totally extraperitoneal or TEP approach. There's this concept mentioned called programmed spatial anatomy. How does that structured approach help during the dissection?
It's really about efficiency and safety through standardization. Programmed spatial anatomy means systematically dividing that extraperitoneal space, the potential space you're creating, into 4 distinct spatial regions during the TEP dissection.
Like having zones on a mat.
Precisely. By sticking to the systematic, orderly approach, dissecting zone 1, then zone 2, and so on, surgeons follow a predictable path. They know which structures to expect where. They identify landmarks methodically.
And does it actually make a difference in outcomes?
The evidence suggests it does. Studies have shown that using this kind of programmed approach significantly reduces operation time, leads to less blood loss, fewer post-op complications, and even shorter hospital stays. It just streamlines the whole process and makes it more predictable.
Okay. And as surgeons navigate this programmed anatomy, what are the absolutely essential landmarks they need to expose and confirm to know they've achieved that critical view of the MPO?
There are a few key ones. First, you need really extensive development of the preperitoneal space, going all the way up to the superior border, seeing those muscle fibers. Medially, the pubic symphysis is usually the first bony landmark you expose in the space of retzius. That's your crucial medial reference.
And inferiorly?
Inferiorly, you absolutely must clearly identify Cooper's ligament. Again, it stands out white, shiny, tough, tendinous tissue. It's not just a boundary marker. It's often a reliable structure for fixation if needed, although fixation philosophy is evolving too. These landmarks provide the visual anchors confirming you've dissected the right space adequately before placing the mesh.
Identifying these landmarks is crucial for getting the mesh right, but mastering the MPO anatomy is maybe even more critical for patient safety, right? Specifically, avoiding nerve injury. Let's talk about those high-risk zones.
Yes, this is absolutely non-negotiable territory for any hernia surgeon. We're talking mainly about the infamous triangle of doom and the triangle of pain. The MPO concept forces you to understand precisely where these are.
Okay, define the triangle of doom first. What's the major risk there?
The triangle of doom is the more medial danger zone. Its boundaries are roughly the vesta ferens medially, the gonadal vessels laterally, and the peritoneal reflection below. The critical structures within it are the external iliac artery and vein. Injury here is obviously catastrophic because of major vascular bleeding. You simply don't dissect or fixate anything there.
Right, avoid at all costs. Then you have the triangle of pain laterally. Fixation might seem tempting there, but it's incredibly risky. Why?
Because it's packed with nerves. The triangle of pain lies lateral to the triangle of doom, bordered by the iliopubic tract, the gonadal vessels, and the peritoneal reflection. This area contains 3 key sensory nerves that are vulnerable during dissection and especially fixation.
Which nerves are we talking about?
You've got the lateral femoral cutaneous nerve, the femoral branch of the genitofemoral nerve, and potentially even the main femoral nerve itself deeper down, though direct injury is rarer.
An injury to these causes?
Chronic, often debilitating pain syndromes. Injury to the lateral femoral cutaneous nerve causes neuralgia paresthetica, that burning pain or numbness along the outer thigh. Damaging the femoral branch of the genitofemoral nerve can lead to persistent pain in the anterior thigh and groin. These are life-altering complications we must prevent.
So given those significant risks of chronic pain, what's the absolute ironclad rule for mesh fixation in relation to these triangles?
The rule is simple and absolute. Do not place tacks or fixation devices below the iliopubic tract laterally or anywhere within the triangle of pain or the triangle of doom. Period.
No exceptions.
No exceptions. Mastery of MPO anatomy means knowing exactly where it is safe to fixate. If you choose to fixate at all, typically superiorly onto muscle or medially onto Cooper's ligament, well away from these critical vascular and neural structures.
Okay. So if surgeons follow these principles, understand the MPO, achieve the critical view, use large mesh with overlap, avoid the danger zones, what kind of clinical outcomes are we seeing today? How does it compare to historical results?
The results, honestly, are why these techniques have become standard of care. Modern laparoscopic repair, when done correctly with comprehensive MPO coverage, yields truly excellent outcomes. We're routinely seeing recurrence rates in the range of 0.2% up to maybe 2.1% in medium-term follow-up studies.
That's incredibly low.
It's fantastic. Compare that to historical rates from older tension-based open repairs, which could easily exceed 15% recurrence. It's a massive improvement, and it really validates the whole MPO principle and the minimally invasive approach.
And finally, let's think about the educational side. For surgeons in training, this MPO concept must provide a clearer map, right? Even though laparoscopic hernia repair has a notoriously steep learning curve.
It definitely helps provide clarity in what can be a confusing anatomical space, especially when viewed laparoscopically for the first time. The MPO framework gives you that systematic anatomical map. It unifies the different hernia types. It helps young surgeons more accurately pinpoint the defect, understand the relationships between landmarks, and methodically work towards achieving that critical view.
Does it shorten the learning curve?
Well, the learning curve is still significant. It's often reported in the range of, say, 50 cases to gain basic proficiency, but maybe up to 250 cases to achieve real independent competence and efficiency. But having standardized concepts like the MPO and safety checks like the critical view are absolutely essential tools for navigating that curve more safely and effectively. They improve the educational process.
So boiling it all down, what's the core message for surgeons today regarding the MPO?
I think the core message is this. Truly mastering the myopectineal orifice, understanding its boundaries, knowing the critical layer is the transversalis fascia, and internalizing the technical necessity of achieving complete, wide coverage, that 37 square centimeters plus overlap, it isn't just, an optional refinement.
It's fundamental.
It's the essential competency. It's required for any surgeon performing minimally invasive hernia repairs safely and effectively in the modern era.
Well put. Okay, before we wrap up, you always leave us with a final thought to chew on. What is it this time?
Okay, here's something to consider. If we accept Frouchot's idea that the MPO is this genetically determined weak area potentially present in everyone, and our surgical repairs with mesh are now achieving such low recurrence rates, what's next? What are the future frontiers? Should we be thinking beyond repair? Could there be surgical or maybe even biological interventions aimed at addressing this inherent predisposition before a hernia even forms? Are we looking at prophylactic reinforcement, maybe biological scaffolds, or even identifying genetic markers for those most at risk? That's maybe something to carry into your practice and think about down the line.
That's a fascinating, forward-looking question. Excellent reflection. And for everyone listening, if you found this deep dive into the MPO useful for your practice or just your understanding, please do us a favor and share it with at least one of your colleagues or friends. Help us spread the word about high-quality, focused knowledge like this.
Yeah, share the knowledge.
Thanks for joining us on the deep dive.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.